So let's welcome to the stage. You've already seen him up here, Derek Asay, Senior Vice President, Government Strategy and Federal Accounts at Eli Lilly. Please come on up and join us. And I want to thank, while I have this opportunity, to thank Lilly, to thank the Healthcare Distribution Alliance, and thank BD for supporting this today. They're going to feed you. They're really going to pay for the drinks at 5 o'clock for those of you who are here. Derek, thank you so much. Thanks for launching. Hey, I guess I'm a sophist on a lot of this, in the sense that if I want to, I can argue any corner of the healthcare equation. I can argue for the status quo. I can argue for change. I can argue, but where my passion is, I sort of see a cluttered system that believes it's doing what's right, that has a hard time lifting up and challenging, that has a very multiple sets of North Stars that sometimes don't align into the one big North Star. I mean, that's my honest view. And thus, there is a lot of inertia that is unintentionally, maybe unconsciously built into the system. And we've titled this session with you, Gut-Punching Inertia in the healthcare space, because I want us to roll a bowling ball into status quo thinking. And I'm not condemning that thinking, because it's there for a reason. That's where the market is, and it thinks it's helping people. But when you kind of look at the overall healthcare system, we've been limited, I think, in vision and outcomes, and had just a lot of this. So you are a major pharmaceutical innovator and provider out there, and you've invested a lot of money, and you've had flops as well as successes. So I just want to ask you, in terms of this gut-punching inertia, what are the skill sets and things that we collectively ought to be more willing to do than we have been?
Oh, that's a great question. I think the biggest thing is, how do we treat disease earlier? So we've got to do more screening. We do a terrible job with that. We don't pay for that generally in this country, and we've got to change that. And we've got to, in my industry, we need to invest in the science to really double down on what are those things that go earlier in the disease.
The country's 250 years old. You're 150 years old. You're looking good for 150.
As I mentioned earlier, we just had our birthday party, but I think the thing is we have had a lot of flops, and you try to learn from those. Alzheimer's is a great example. We've had a number of, we've studied Alzheimer's for north of 35 years, and we got our first drug on the market literally 2 years ago.
Is it a mistake that the pharmaceutical industry doesn't talk more about flops?
It is, I think, and I think we internally learned from those. We were studying the disease too late in the case of Alzheimer's, and we needed to move earlier, and so we've learned from that. I don't think we share enough externally about those. Probably don't share enough broadly about those. But I think that's where it is, double down on the science, but also working to change the ecosystem so that there's incentives for providers to move earlier. And that's cuts across multiple.
I'm always interested in the secret sauce of companies like yours, where you've been resilient over such a long period of time and continue to be out there. But I think one of the challenges, so we're here today, we've been talking about obesity and new obesity drugs. You are a leader, innovator in that space. And I don't know how to say it, so I'm just going to be blunt. A lot of the communities that desperately need these drugs covered in Medicare, Medicaid, are having a hard time getting coverage for this. And so does that upset you?
Oh, tremendously. And luckily we're making changes on that front.
Right.
And we announced in November an agreement to be able to provide obesity medications in Medicare and Medicaid. The Medicare part, which is going to be done under a program called Bridge, starts just in a few weeks on July 1st. I think it's going to be amazing for Medicare patients for chronic weight management. The coverage criteria that the Medicare agency has set is a little tighter than a label, but it's pretty broad. It's probably, in our mind, about 80% of the patients.
Right. The Trump administration came out and were very proud of what they did with you and the deal that they cut on that. And I remember the day it happened. I remember seeing a number of the people living it up at Cafe Milano after they'd kind of done this big thing. But have you, what was that, like 3 months ago, 4 months ago?
Well, it was in November, so
yes.
6 months ago.
So since that time, have you seen, tell us how the behavioral shifts in the country have gone, and are we reaching more of the communities that have not had access, the accessibility issue, which you and I were discussing last night and this morning?
Right. Well, it actually starts for Medicare on July 1st.
Okay.
we're very big advocates of starting April 1st, but we couldn't quite get there. And there's a lot of implementation. So it's going to start on July 1st. For eligible patients, a $50 cost sharing. So I think it's going to be huge because there are, literally tens of millions of Medicare beneficiaries that have, a diagnosis of obesity. So I think it's going to be a really, really good opportunity.
But not in Medicaid yet.
In Medicaid, it already could be starting. We've got a lot of work to do in Medicaid. So it's the same pricing. It's a $245 discounted price. I think today there's about 13 states in Medicaid that are covering obesity agents, which is a start, but that's literally, just literally over a quarter of states, and we've got to do better in Medicaid. Because I think one of the challenges we have is, when so many patients need this, and particularly Medicaid patients, we need to make sure those vulnerable patients have access.
And is there enough data out there? I mean, I was talking to our friend over here who's my AI diva. Sorry? Yes. Claire, we had dinner, and it takes me a couple of times, Claire. So, but Claire was sort of talking about this from the point of view about the very different systems, the bad data that goes in. I'm interested in whether or not, after you begin seeing the uptake of this among communities that had been part of it, and you monitor and hopefully you see positive impacts on obesity, which I am sure we will, but I think it will depend upon a lot of other factors as well, and the kind of ecosystem which Scott, we were just talking about. But if that's monitored over time, and then you begin to see that, and then will you be able to see the fact that other health challenges that they had may be dissipating? In other words, are you going to be able to measure the net health gains in people in terms of things that have not developed given population dynamic? I know that's a complex way of saying, hey, you're going to be able to measure your success.
Oh, I think absolutely. And we're in the early innings really still. Our first drug, Zepbound, came on the market 2.5 years ago, but we're already starting to see a lot of that. There's, as you mentioned, other disease impacts of obesity. There's over 200 chronic diseases that are related to obesity. So, Zepbound has an indication for obstructive sleep apnea. We had new data come out on a molecule that's not yet approved by the FDA, but showed reduction in chronic knee pain. So I think there's a lot of opportunities, and I think there's going to be more and more. I think we're studying across the molecules that we have in this space over 30 different disease states with 100 clinical trials. And so there's going to be a lot of that. And I think the cost data will start to come too. I think the most important thing is the impact that we're having on patient lives. And even this morning, I've had 2 people come up to me and say, hey, Zepbound has changed my life, and which is great to hear. And but I think it's as more and more data comes out, we'll even see a bend in the cost curve as it will be.
What do you see happening out in the ecosystem? So I'm going to tell everybody, I happen to be a client of Lilly Direct, and I'm taking it. And it's been very helpful to me because I've, particularly as I get older, it's, a challenge. And let's face it, I live a life around dinners, fancy dinners. It's like what I do. It's a challenge to be the DC guy that hosts more dinners than anyone else. But in the process of this, I've gone through the jungle a little bit personally, where I didn't, my insurance company for the company that I have would not cover this, just wouldn't cover it. So if anybody knows one that will, let me know, but would not cover that. So I jumped in because it was easier and it was easier to market to HIMSS. There's HIMSS, there's Roe, which, one of the great tennis stars is pushing like this. And with all due respect, in case any of you are affiliated with them, didn't have a good journey in that space. I sort of felt like I was doing it because I wanted to be in it, didn't know how to hook up with Lilly, thought you guys were going to cost a fortune. And then I shifted from this to Lilly Direct. And so I went to Lilly Direct and now am in that pathway, really enjoying it. I found the support. So it's not to make you feel good because I'd tell you if I was upset. But I'm interested in that because it can be complex for people interfacing. And I'm interested in, I was upset at my insurance company because I couldn't get what you had through that. Now I can talk directly to you without actually calling you specifically. I can call Tracy Sims, but but I'm in that space. But why? How has that gone, Lilly Direct? Because it's such an avant-garde way for Americans to get this drug.
It's been amazing. I mean, I just looked at the data, and we're just about 50% of new scripts for Zepbound go through Lilly Direct, the self-pay channel. So on one hand, you say it's amazing we're able to serve that many patients. The goal ultimately, though, Steve, is to build the case that insurers want to cover, because that'll make it even that much more less expensive for patients. But
are you getting success there?
We're getting there, and it's picking up. I think the Medicare and Medicaid, the balance and bridge models will be very effective and help push commercial insurance. And part of that's on our side is to put out more data and show the benefit, not only in the broader patient benefit, but the cost benefit as well. But on Lilly Direct, I think for us, it's not about trying to replace the current pharmacy system and all that. It's really about more of making it a better experience for patients. So, and access to a lower price, and I think they really go out of their way to try to make it a very good customer experience.
Do you think you're going to do direct-to-consumer in other products?
We do already.
Okay.
Now, what I would say is I think that'll be a much smaller play, because for most of our products, they're broadly covered on insurance. So Mounjaro, for example, broadly covered on health plans for type 2 diabetes. So it will be an option. It's not going to be, in my opinion, the option that we see in the obesity space, largely because there's that gap in access that we're.
How many of you here find the developments and ecosystem in the new obesity realm interesting? Some of you do. So let's bring this guy a mic here in the middle. You, right there. I just want to get your. We have a microphone? Okay. Where are you guys? Come on. Give her a round of applause. Move. Okay, here we go. Would love, because you said you're interested. So we have a person, innovator in this space. Would love to get your take.
My name is David. I think one of the barriers to the use of new obesity drug was the cost and the insurance not paying it. So Lilly Direct is helpful, but we need to do better.
Continue to do better. Okay, great. Thank you. Let's go to, the gentleman I wanted to go to disappeared. He was over here. Where'd he go? How about somebody, who else put up their hand? Right here. Let's go to the doctor here.
Yeah, hi, Dr. Ernie Lockrow. I'm actually with the government, Uniformed Services University.
Oh, great.
So
where is that based?
it's right next to the Naval Hospital, what used to be the National Naval Hospital, across from NIH, Walter Reed National, back in the back, it's on the campus there.
So how high is obesity on your radar screen?
I mean, I think obesity is not a big problem with the government, I mean, active duty military, so we don't have as...
Because Secretary Hegseth's gotten rid of everybody.
Yeah, right, yeah. Exactly, yeah. But I think where the issue is in the retiree population.
Yeah.
And so I fit into that category. Full disclosure, I'm on Mounjaro, for diabetes, and I don't have a problem with access because I'm with the government. TRICARE covers it, so has always covered it. But it didn't cover it. TRICARE would not cover Zepbound, so they had to pay out of pocket for if somebody wanted to go on Zepbound. So, and I didn't know about the Lilly Connect Direct. That's kind of good information to pass out to folks, but.
It's actually really good. They overpack the materials. It's like really, it comes in like you spend way too much money in packaging. I can give you some counsel on that. Thank you. How about another person on this side? I'm going to go to this guy. Yeah, why not? You're here. You're front row.
Go ahead. Make sure I know what the question is.
So the question is, as we kind of talk about the ecosystem with a big pharmaceutical company that's addressing a systemic, I look at it as the tectonics. They've created an earthquake in the right direction, in my view, but would love to get your take or question.
Yeah, I'm not sure I'm qualified to answer it, but I do, I will tell you this. I work for a small government agency.
CIA? Oh, it's
small.
Okay.
It's actually the U.S. Fire Administration.
Okay,
And so firefighters interface typically with, because they work late in life or later in life to some degree, they experience some of the diseases we're talking about. But
right.
In emergency response, they experience what we're talking about a lot because
right.
there's a lot of patients out there. So I think that's probably the only part that I'm qualified to really speak.
Well, I would say to you, and so thank you for what you do. We did a program recently where I was looking at the most stressed out people in society, in American society, are firefighters, first responders, emergency people, healthcare folks, people that are serving the military, I would say teachers, they've got a lot of people out there, and I don't think we focus enough on their health. And so when you look at their health profiles, they're radically, and society would stop if they weren't doing what they're doing, but they're kind of the overlooked part of the social equation. So we've just had a couple of snapshots of perspective, Derek, and would love to get your thoughts and just reaction in terms of this and what you've done, because you've moved at lightning speed in bringing these products online. But as you kind of look at it, look at the lessons here, and I'd love to know what your next bold bets are.
Well, I think on the comments on obesity, there's no question that we have to broaden access. So we're doing that in Medicare, we're working on that in Medicaid, and we have to continue to do that with employers. We started at the end of the year an employer direct, Lilly Employer Direct. So we're trying to figure out how do we expand that so that ultimately what the goal is obesity is covered like every other chronic disease, and that's what we need to have happen, but we're not there yet. We've got a lot to do to get there. So I think we'll have more and more announcements. We work every day on this. One quick story: when we announced the day that we announced the expansion of this with the president on November 6th, my mom called me that night and she said, "Well, did you have anything to do with this?" And I said, "Yeah, just a little bit." And she said, and then she went into stories of our family of people that didn't have access. And I said, "Mom, that's exactly why we did this." And it really is. One of them was my sister, and luckily her employer now covers it and she's able to get it. But that's, I hear those stories every day. I think people know we just announced a couple weeks ago we got our products back on Zepbound. I got multiple texts every week for months from friends that said, "Hey, when are you guys going to get Zepbound back on at CVS?" And we were able to. It took a long time, took about a year, but we wake up every day in our world trying to figure out how do we make sure that everybody has access.
Well, with that, I just want to thank you for supporting today's conference. Thanks for coming to have a candid talk with me about where this is all going, and thanks for Lilly Direct. So, Derek Asay, Senior Vice President, Government Strategy and Federal Accounts at Eli Lilly and Company. Thank you so much for joining us.
Perfect.
Thanks
Steve.